Hello, everybody again. I'm Ed Kim from Seoul National University Hospital. As I mentioned in the other day, I'm very glad to talk to you about my favorite subject on imaging of the infection and inflammation. As you know that the infectious diseases are still major clinical problems, particularly with COVID virus pandemic. We are more concerned about the infectious diseases, and we have to learn a lot more about this terrible diseases. As you see on this slide, tuberculosis is still number one sort of infectious agent, and many other virus, some bacteria still remain. And because of a continuous biological mutation of these all bacterial viral agent, we are living with this all the germs continuously. And as you see on this slide, infectious disease is still a major killing problem. As you know, COVID virus already killed probably more than 3 million, although it is 2% of infected 150 million people in the world. So morbidity is another problem to give us a big burden. So financial big burden is obvious, as you see on this slide. And so we estimate by 2050, all this antimicrobial drug resistant infection will become continuous leading cause of death in the world. So practically, we are seeing a continuous increase in sort of a prosthetic replacement in the knee or hips. And then obviously, almost 2 to 5% become infected. Once the infection occurs in the prosthetic replacement, that they have to continuous problem with another one. So this will impact on clinical medicine. All this orthopedic surgeons make a lot of money because of continuous this kind of problem related to implant, other things. And so diagnosis of early infection is still a major clinical problem. As I said, diagnosis of thromboembolic disease or this kind of early infection like a fever unknown origin have been major clinical problem and challenge. So if you have a particular interest in this subject and then make any new diagnosis or therapy in this thromboembolic disease or infection, you'll be rich and famous very fast. So as you know, antibiotic overuse are well known, and just like steroid overuse. And so these antibiotics help in certain infectious problems, but overuse also makes lots of problems. I will mention later on. It reduce our immunity because of killing maybe good bacteria in our gut. So that's a dilemma. As you know, in this slide, there are many different kinds of antibiotics. Inhibition of cellular wall of bacteria, this vancomycin, which is broad spectrum, and then penicillin certainly, and some cephalosporin, those are things. And then some drug, commonly we use sulfur. A sulfur drug is inhibiting folic acid metabolism. And certain polymyxins, daptomycin, that's also inhibiting cytoplasmic membrane structure, as you see on this slide. And then we have some agent like a quinolone. That's particularly cipro, we call ciprofloxacin, common drug we use. That's directly inhibiting protein synthesis through DNA. And actinomycin is on the other hand suppressing DNA synthesis. And then rifampin is another common drug, rifampin, that's inhibiting polymerase and DNA-directed RNA synthesis. So all other common drugs like erythromycin, clindamycin, those things also inhibiting a protein synthesis in the ribosome. And other tetracycline, streptomycin, gentamicin, all common drug, nitrofurans, all also suppressing, inhibiting protein synthesis. Other puromycin also do, that's also suppressing protein synthesis. So how this become resist in our body? Well, when you give a certain antibiotics, and then you killing or inhibiting all this mechanism, not in 100%. So there is some resistant cells, and those are regrouping, and then bacteria will regrow. So that's the problem we see even in the virus. Also, there's always some kind of in biology, all the living organism try to be survive. So they change their own genetic properties and then regroup like the cancer as well. So how this happened? There are several sort of mechanistic reasons. Decreased uptake is one reason, and some targets become changed, and some all kind of enzyme activities are also changing and or inactivating. And then finally, there is a so-called efflux pumps. The drug cannot stay inside the bacteria or virus, it came out. So these are multiple maybe mechanism work together to create the resistance. As you know, there are more than 1 trillion species of microbes, human microbes on our Earth. And the bacterial cells in our body is more than 100 trillion. That is about 10 times more than our total body cells, usually 10 trillion. So there are more than 30,000 known microbe species. In our mouth, there are more than 500 species. So bacteria has a single cell accumulating certain substances from environment. And the virus is smaller than bacteria from the bits of DNA or RNA escaped from the genes of other large organisms. And there are more than 320,000 mammalian or avian origin of virus on Earth. And there are 3 or 4 new viruses per year generated. So in each of 50,000 vertebrae, including human, there are more than 20 viruses living in the system. So average person can have a cold almost every year. They have more than 10 viruses per person. Usually around 200 virus species infect humans. So just the COVID is another such a virus. It's nothing to be surprised. And in the human, we have sort of 5 major categories of microbiome: bacteria, virus, parasite, fungi, and archaea. And they are spread throughout our body system. And you see, all organs can be infected by these things. And particularly this, majority are in the gut, but you notice that the hand and forearm is almost like 29%. And that's why we have to wash hand and forearm a lot more frequently. And there are always good and bad things in our body system. In this kind of bacteria also, there are good bacteria and bad bacteria. So representative one here, Lactobacilli is good, and then but Clostridium, Enterococcus, E. coli, those are bad. So you have to try to eat a lot more fermented food, like tofu, some we call some soup, and then some natto, Japanese natto, or some yogurt in American diet. Those are the supporting or lactobacilli. But if you are taking more than 7 or 10 days antibiotics, then you killed all this good bacteria. You are supporting bad bacteria. Bad. Certainly smoking, and then alcohol, obviously, alcohol, smoking, stress. You see, this stress is supporting pathogenic bacteria. And these are, in the gut, we have such 200 billion bacterial cells, and 60-70% are good bacteria, 40% are this kind of pathogenic bad bacteria, they are homeostasis equilibrated. But if you take so much antibiotic, chemotherapy, stress, they all destroy the balance. And then this pathogenic bacteria, which is supposed to stay in the gut, but with that unbalanced environment, this pathogenic bacteria try to came out from the gut, usually into the liver or lungs with the mutation. So that's some people call superbacteria. That is a major problem now in the world, particularly in the hospital. If you stay in the hospital longer, you'll have an infection with the Clostridium. And many cancer patients, almost in my view, all cancer patients died of pneumonia, which is not treatable by common antibiotics, because those are all superbacteria. Because those people suppressed their immunity by chemo, other things. And they also make this unbalanced bacterial groups in the gut. And that's why they have all kind of superbacteria, which was not reported well in the literature or publicly. But for last 10 years, we recognize things, but there's nothing we can do much nowadays. There's no antibiotics because of such a mutated bacteria. Many drug companies are reluctant to make continuously mutated bacteria or virus because it takes a long time to get the FDA approval. By the time they're going to use, and then their drug are not working because already mutated bacteria or virus. So that's a dilemma we face. So it's the bacteria functioning in the various things, as I say, good, bad, but the important thing is like in the brain, okay, they activate the vagus nerve, immune system, and then secret neurotransmitter. Serotonin is produced in the gut, but works in the brain, like that. And then, as I mentioned, in the gut, there are so many bacterial cells. They are, making a vitamin, important vitamin, and particularly immune system. So if we have antibiotic abuse, then you'll end up having very weakness with low immunity and no vitamins in general. And obviously, bacteria, certain bacteria defend airway against pathogens. So it's bacteria can involve the lungs through the bronchial system, but many times we have common cold, other things, but it just go away because we have a defensive system. And certainly wound healing, inflammatory control, immune system, all things. So there are many protective ways and certain metabolic or immune activities by the gut. I already mentioned. So recently, for example, in colorectal cancer, in the gut, they found Fusobacterium nucleatum. Okay, and this one is related to this microsatellite instability. So this help the tumor growth. So this is a good bacteria in colorectal cancers. And the E. coli things carry certain enzymes, and then makes some kind of colorectal carcinosis. There's a pyroloid. Can you mute your things? Okay. Now, in the last 100 years, there are almost 10 major problems with certain viruses that here in Africa, and there was some Marburg, Ebola, and rabies. And obviously in United States and Africa as well has HIV, AIDS viruses. But the whole world were sort of infected with smallpox and this influenza. The Spain influenza killed a lot of people. And then, yes, dengue is still in Thailand as a problem. But the SARS coronavirus was in China 2002, and the Mediterranean coronavirus 10 years later in Saudi. And this SARS coronavirus 2, which is COVID-19, that's in China. So the and then as you see here, in the human virome, there's lots of DNA, different 13 genes, but RNA genes, and then but this bacteriophages, that's 52,000 genes, some overlying here. And there's a human strain and an avian strain combining together will make a new highly pathogenic strain. This kind of things is mutated continuously. They mix together in genes and make a continuously mutated genes. And the viral infection can occur in every organ system, as you know, and rhinovirus, common cold, but or encephalitis, meningitis, or pharyngitis, or this cardiovascular system, liver, skin, so many skin, and then the eyes, parotid, and the lungs, and then spinal cord, gastrointestinal tract, and pancreas, and certainly sexual sort of a transmission. So all organ system involved with the virus. So how that works, and the virus entered body cells and releasing RNA, and then invade the cellular nucleus, and then create a new RNA and more viral particles. And these new viral particles are released and destroy cells, that kind of sort of continuous cycle. And so this SARS-CoV-2 virus is a combination, more likely, SARS, MERS, SARS-1, and MERS. And then curiosity is how they entered our body cell. They have spikes here. And these spikes attached to angiotensin converting enzyme 2 receptor, etc. And then, so that's a receptor apparently is so important with a certain spike of protein. So it's not so clear apparently. But in healthy tissue, when the virus, there are alveolar macrophages, phagocytize the virus, other sorts of things, and then there's no virus enter the cell, and this kind of immune cell CD4, CDA works, but in case of certain vascular, some leakage or some, then there's a so-called cytokine storm. A lot of the IL-6 particularly, this pro-inflammatory cytokine is too much produced, and then apparently the immune system is dysfunctional. And so it's so much cells, all these things, and they develop some symptomatic pneumonia, other things happening. But the entering cell is still somewhat curious. And then another diagram shows some sort of, you see this, when the virus comes in, it's attached to angiotensin converting enzyme 2, but also this transmembrane serine protease. Protease usually melt this cellular membrane and comes in, and then virus replicated. So RNA virus. This RNA makes a DNA protein synthesis, and the virus released. This apparently AC2 and transmembrane serine protease 2 are the key role for virus enter the cell and make a RNA, DNA, and protein synthesis. So this apparently is all big family, and some SARS-CoV-2 one of the groups. And again, because a similar message is all detailed anatomical structural information, spikes, the membrane, all the envelopes. And then it's ACE2 that mostly in colon. Lung has also this one, but almost every organ has this ACE2 receptors here. So this so that's basically. So again, in 2003, SARS started in China, and then makes a acute respiratory syndrome. That time, none of Koreans were apparently infected because of kimchi, which is a spicy, vegetables that apparently has maybe some sort of substance to increase the immunity. I don't know, but a lot of people say about kimchi. And then almost 10 years later, Middle East respiratory syndrome, that's called MERS COVID. And so this current COVID-19 apparently has some combination in genetic structures. So it's mutated, all these are probably related, but mutated. And the, it's infection is now probably 150 million, 150 million. And then death is about 2%. But it's much more than SARS and MERS for the infection, but death rate is probably less than MERS or SARS. Now it's about 2%. And so, compared with other all this virus and the the measles are much more contagious here, and the Ebola, bird flu are much more also deadlier. So corona virus is right here. It's similar to flu or polio, not common cold, but flu, Spanish flu type things. In terms of some slight contagious and also deadlier. And so how this is transmitted, mostly through the respiratory drop or aerosol. So that's why we need the mask things, but also some through the toilet. And certainly droplet on the surface, they're like handles, doors, or in the subway system, a lot of people hold a side bar, that kind of things, door handle, glass, a cellular phone counter. So that's indirect. So, but directly this droplet. So that's why the mask is key for preventing transmission. And the this spike protein, all this Aberrant protein have been now well studied and to make all these vaccines. But looking this clinical stage, early and pulmonary stage hyperinflammation phase is a long time course, and certainly mild clinical symptom or no symptom, and then some develop shortness of breath and acute respiratory distress syndrome, died, that kind of, and then certainly temperature increase in this period, and the chest X-ray show abnormality in this period, and then all this inflammatory markers, cytokine IL-6, and then thromboembolic D-dimer, and CRP, and troponin, all this elevated this stage 3. So for the treatment, we have to improve the immune system in this early stage, and then some the viral drug, chloroquine or remdesivir, and the some plasma transfusion, as well as a corticosteroid and IL-6 inhibition, etc. So in this virus, there is always a inflammation, thrombosis and inflammation together. And the so how this happened? Well, certainly some endothelial damage and makes a microthrombosis and makes a certain acute respiratory distress syndrome, nephropathy, hypoxia, and macrothrombosis, venous arterial thrombosis. So it's a pneumonia is a common problems, and the so in the alveoli We have lots of this kind of immune cells they are fighting against, but again ACE2 attach, and then some kind of this immune sort of a storm, cytokine storm, makes all this trouble, and then pneumonia developed. So T cell or this response in the inflammation, as you see here, mild, severe, and mild age group, and some it's different, young, old age. Old age already have some decreased immunity, and so they do have more clinical symptoms, and then death, and certainly other immune cells have been well studied. Generally with this viral infection, all these immune cells are decreased. B cell also is sort of modulated by age group and disease severity, as you can imagine. This earlier I showed some mechanistic, diagram, and same thing, and all this inflammatory sort of responses are correlating with the disease severity, as well as all immune cell responses, but still not well explained. A lot of things with age things. So we still need a lot more information. And the NK cell also exhausted with this kind of infection in old people. Some monocyte dendritic cell, the same thing. All this is changed with the infection. And so clinically, all this inflammatory symptom signs we can expect. So it's not easy to pinpoint and separating from other influenza, other viral infections. It affects all organ systems, things, but surprisingly many do not have any symptom at all. And so this, in a mild asymptomatic case, it's slowly. And so asymptomatic usually, incubation period, which is 2 weeks, and then start some fever, and then slowly developing chest symptom, dyspnea. Usually takes another 2 weeks. After that, that's either lung or cardiac or multi-organ failure, intravascular, even thrombosis, disseminated intravascular thrombosis, and died. The interesting thing is that this coronavirus has been more in males, 3 times more than the female usually. And then why, we don't know yet, but they say that female hormone, estradiol in this case, or progesterone, these are all regulated inflammatory response. So apparently these female hormones are very helping of our immune systems. So that's why they have less infection with this coronavirus. So there's apparently, so some studied male hormone is still questioning. Apparently transmembrane, this, and the virus entry, as I said earlier, angiotensin converting enzyme 2 and the transmembrane, this has to be activated and bind to permit entry. And the androgen receptor may be working things, but it's not yet recognized. So only female hormone. And so, but interesting recent report that prostate cancer patient who receive a Lupron, that's a sort of a making a female type person, develop much less this coronavirus infection. So definitely this estrogen helps for this virus infection. But the exact mechanism is still unclear, but testosterone rather maybe increase certain viral proliferation things, but the estradiol or female hormones may suppress things. So again, now there's like a symptom, and after a few weeks, the patient develop antibodies. So in very early, less than 2 weeks, it's difficult to detect the virus. But after incubation period, the PCR, so by nasopharyngeal swab, show positive. So PCR should be useful. And then after 3 weeks, 4 weeks, the positivity by PCR is down here. And then this virus initially isolated here, and then IgG is starting here. So by PCR, if we have IgG antibody, that's indicating the infection, viral infection. If we have a vaccine things, we expect to have IgM antibodies. So diagnosing of this kind of virus, and certainly it's immunoassay, and the certain PCR show certain initially maybe circulating DNA or things may show, but currently PCR is the most reliable to pick up. And the there is a so-called cPass kit. This based on competitive ELISA methodology, and it will detect neutralizing or blocking antibody in the sample. And then, so it's a negative, positive test show here. Yesterday, Korean news report a very simple home kit to have this kind of positive, negative test with $10 price. That's great. But if a patient does not have enough immunity, it may not be detectable. They say only PCR can detect. So this is another some virus neutralizing assay, and this new method by gene script utilizing recombinant proteins. This is fast, automated, and then any lab, and then the high throughput and more consistent. So this kind of new recombinant protein virus neutralizing test will become more popular. So it's a biomarker has been this kind of sort of a biomarker, but it's a variable things. So for therapy, initially, blocking some certainly important proteins, particularly ACE2, and then certain protease inhibition, because of this transmembrane, this enzyme is another important. So inhibition of this, and then effective T cell, our immune cells, boosting immune cells, or certain filtration of this kind of pro-inflammatory cytokine, IL-6 filter. So this kind of, and then so there's now phase 1, 2, 3 studies going on. And certainly there's a treatment, all this worldwide now working, and then monoclonal antibodies trying to fuse all this important proteins, and then utilizing all this viral drug and this kind of proteolysis, remdesivir, that's chloroquine here. The exact mechanism of chloroquine malaria drug for this virus is still unclear, but they try to inhibit the RNA replication things, and then so again, they try to block entry of virus, and there's a many sort of ways, and this certain quinoline, certain autophagosome, and this, and certain DNA, RNA sort of, and there's many and modulation of immune cells, macrophages particularly, and some this kind of MAPK and P30A gene sort of regulation has been studied. And so antibodies against this SARS virus receptor sort of binding, and some this sort of a membrane fusion, and certain all this monoclonal antibodies against this certain cellular membrane, or the spike proteins they call anti-S spike protein, anti-angiogenic antibodies have been developed and testing now. So this vaccine is certainly the best way to possibly prevent certain viral agent, but the continuous mutation seems to make a difficulty to make this kind of vaccine successfully, unless we have a continuous vaccination with the new sort of either messenger RNA or some DNA. That kind of, certainly live virus is more maybe efficient, but great risk in patient with immune deficiency. So vaccine is most impactful medical intervention in our history, but well, there were quite a death. No. So this is a what? I'm sorry. This this vaccine prevent 100 million deaths in the United States, and also 2.5 million deaths worldwide. And there are active components, adjuvant, antibodies, antibiotics, and preservatives, stabilizers, and trace component, all these kind of things together. So each component has a certain different characteristics. So now it's a concern that why is many people assume that there are too many vaccines too soon, and then because but in reality there is much less amount, much less now, and then some concern too many vaccines may mess up immune system, but there is no effect on this kind of things. And there's certain, smallpox, all these vaccines have been sort of assumed to create autism, but there's no proven document yet, but who knows? And the certain vaccines include autoimmune disease. Well, there's still no evidence. And there's certain miscarriage risk, but no evidence. There's all this in the literature, no evidence. As you all know, Pastor, use first attenuate organism, rabies or things, but this Carmel-Garin also use a mycobacterium. So it's a very successful in smallpox, polio, measles, but there were quite a risk because the live vaccine, and then actually 40,000 children developed the polio, unfortunately. Fortunately, there was no CNS environment, but 56 developed a paralytic, or 5 died. So this kind of things happen. And measles also showed certain pneumonia, pleural effusion, rash, etc. things. So we need more vaccines in this kind of HIV, COVID-19, certain bacteria, fungi, parasites, but vaccines against influenza, malaria, TB have not been successful. Why, we don't know yet. So the COVID-19 vaccine has been now working on many different techniques, DNA, messenger RNA, most messenger RNA, Pfizer, Moderna, messenger RNA. But the DNA and some adenoviral things, some AstraZeneca, probably this kind of adenoviral, Johnson adenoviral. And so it may be more effective, but much more risky. So different techniques. So a DNA vaccine has some maybe more cost effectiveness, but less immunogenic. RNA is rapid and protein antigen only, but certainly keeping It's safe, it's not apparently easy. So, and there is a so-called bacterial eater, they call Bateriophages. Some bacteria eats. So some even try to use this Bacteriophages for the therapy, which is against some antibiotic-resistant bacteria. So it's somewhat successful. So we need more of that kind of things. So and either imaging or treatment, etc. We for infection we have to think about pathogen, bacteria or viral itself, and whereas a host immune response, and so and we have to think about treatment and also diagnostic, certain blood, sputum, CSF tests, and the so this kind of all together should make a cost effective. And again, these are all just more like an immune cell response. So we have to recognize and monitoring this inflammatory response for the immune treatment modulation things. So not only cure or inhibiting certain mechanistic factors, we have to continuously work on this our individual immune system. And so okay, it's let's have just a 10-minute break, and then we'll talk about imaging, real topic of today's lecture, imaging of infection and inflammation. So just 10 minutes later, we'll start this imaging part. All right. I'm gonna start talking about the imaging of infection and inflammation. By the way, I hope you hear me well. If there's a problem, let me know. Now, we have to clearly define infection versus inflammation. Infection is a microorganism itself, but infection is often associated with also inflammation. Inflammation is a tissue response to injury due to trauma, tumor, ischemia, any foreign body as well. So immune cells and certain proteins and chemical mediators are working in the area of inflammation. Inflammatory response by cytokine is related to blood flow and permeability and certain chemotaxis and other proteins, antibodies, as well as chemical mediators. Therefore, it is almost impossible to separate infection, inflammation, and inflammatory response on conventional imaging, like a CT, ultrasound, MRI, even nuclear medicines, because there is always increased blood flow in the inflammation, infection, inflammatory response. So when there is an increased blood flow, there is always increased uptake of any radiopharmaceuticals. Therefore, it is useful to analyze the patterns of uptake, patterns of abnormality, utilizing morphological, structural information from CT, MR, ultrasound, and functional metabolic information from pad or spat together. And certainly serial study is also helpful in separating those conditions. Excess is generally pus pocket. It has a lot of neutrophils in response to infection or foreign body. So on CT/MR, we often see a air in the center of pus, air, necrosis. Now, FUO is defined by the 3 weeks of illness, sickness, or more than 3 days of hospitalization with the fever. Fever is greater than 38°.3 or centigrade, or 101 degree of Fahrenheit. Now, we still have a problem to find the source of FUO in 10 to 15%. But utilizing all the various imagings, we find the cause or source of infection, fever, in 80%. So to specifically imaging bacterial infection, there have been 3 categories. Utilizing metabolic imaging, using sorbitol, that's a sugar alcohol. Apparently bacteria like sweeten. Methionine, or the protein synthesis, or certain nucleic acid agent. Yeah, this labeled with mostly C11 or fluorine, that kind of uridine substance. And then certain antibiotics, as I mentioned, receptor or direct sort of this antibiotics labeling. And then certain bacterial surface targeting using ubiquitins and certain nanobodies. Oops. So we like to have some agent which we can clearly differentiate inflammation from infection or inflammatory response. Mm-hmm. So there's a lot of immune cells are working in inflammatory process here. And the inflammatory response is also related to many cells, as you see on this slide. Bacteria coming, and then certain peptide formation, and the macrophage, liposaccharide, and then certain inflammatory cells and immune cells. And so all these things. So in the tissue, blood, endothelium, epithelium, all these different cells are working. So again, if you are getting old, you expect a decreased integrity of blood vessel, and then response to the injury. So that's they can have amyloid angiopathy, and then plate turnover is slower, and so all the people has less sticky platelet, and the on the other hand, there's a tissue plasminogen antibody release is increased with the aging process. And certainly thrombin generation also increased in this. And the D-dimer inflammatory markers are increased with age. It's falsely positive. You have to know these things. So inflammation, I just say again, is caused by various cancer, diabetes, bowel disease, COPD, cardiovascular disease. So about 15% cancers are often relate to inflammation. As you know, stomach cancer relate to Helicobacter pylori. All this hepatomas also relate to virus, and human papilloma virus caused cervical cancer. Epstein-Barr virus caused nasopharyngeal tumor, or HIV virus is sarcoma. Now, this cytokine-induced sickness cause anorexia, fatigueness, and depression. That's a cytokine IL-6, TNF alpha usually. And there's a toxic effect on pituitary gonadotrophin, and that the affect ovulation, and certainly inflammatory. There's called inflammatory breast cancer, diffuse mass, and very poor prognosis. And so, injury or infection comes, and a lot of inflammatory process by all this immune cells, certain macrophage, all this polymorph neutrophil, all the things. And in the blood vessel, there's all permeability, some component here, things, and makes healing things. So our body trying to heal or automatically by all this cells, and finally fibrin attached. So acute inflammation is often related to innate immunity, and chronic inflammation is related to adaptive immunity. And so bacteria, virus comes, and then the immune helper cell, TA, often try to work hard and makes healing. And the chronic is a continuous process. The immune cells trying to make a healing things, but this is a continuous process. So in acute inflammation is often related to allergic reaction, chemical irritation, infection, trauma, burns, last wounds, and frostbite. And that goes to chronic. In the chronic, you can connect to cardiovascular, neurology, autoimmune, rheumatoid, cancer, lupus, fibromyalgia, chronic fatigue syndrome. So basically, inflammation is triggering all kinds of diseases in our body system. So in the chronic inflammation, you can see all depression, Alzheimer's, Parkinson, all kind of neurology, and all diabetic complications, pulmonary disease, bone and joint arthritis, rheumatoid, and metabolic diabetes, fatty liver, and cardiovascular, all these things, and autoimmune disease, cancer. So it's chronic inflammation is a major problem. And wound healing versus cancer growth is a very similar pattern. That's why we have a difficulty try to diagnose residual versus recurrent tumor in the area of previous surgery, radiation, or even chemo, because the biological findings are very similar. Okay, there's endothelial proliferation for healing, and some in early neutrophil accumulation, later lymphocyte, and all this immune cells, macrophage things, and then a lot of platelet fibrin, and then the cytokine and epithelial. So it's a very similar process. That's the problem we have. So again, it's inflammation started, and then obviously all this process require a lot of genes, intervention, and as well as environmental factors. So certain cytokine, chemokine works, and then certainly all this malignant changes, and then invasion and metastasis. So and then again, in the tumor development, a lot of things combining together. The inflammation and therapy-induced inflammation tumor, and the mutation, gene instability mutation, and environmental dietary things. And all this makes a continuous sort of gene, influence, and then tumor progress. And angiogenesis is certainly supported. So again, these are all more likely the immune cells show anti-tumor effect, and some promoted all cytokine antibodies, all that immune. So again, cytokine, this kind of IL-1, TNF, interferon, this is pro-inflammatory, this one, but there's a anti-inflammatory cytokine here. And so they are balanced. So our body system always work on this way. This same cytokine, but one side is helping inflammation, one side is sort of against the inflammation. And here, this excessive inflammation, angiostasis, and tumor. And here, inflammation limited and tumor restricted. And the certain inflammation, neovascularization, tumor growth. All these things. And the chemokine for inflammatory breast cancer has been known. So this is one of the inflammatory chemokine, and that's related to also cancer. So if we suppress that, we expect less metastasis. But this sort of genes also promoting metastasis to the bone, liver, lung. So there's certain stromal remodeling, inflammation, and angiogenesis, lymphangiogenosis will promote progression of cancers. So antibody against the CXCR4 has been on the trial, in clinical trial. Heart failure also has been associated with the chronic inflammation. Certain inflammation make some epicardial fat, and certain fibrotic process of underlying tissues. So atrial dysfunction, arrhythmia, heart failure, and some coronary atherosclerosis can be related to chronic inflammation. So they call autoinflammation. Again, this kind of cytokine, TNF things. And NF-kappa B is an important gene in controlling inflammation, infection, and also cancer. So the Celebrex drug, which was developed from aspirin, inhibit NF-kappa B. So we use such a Celebrex drug to prevent cancer, particularly colorectal cancer. So this kind of various gene sort of changes help to understand this inflammatory process. And there's called inflammagome, inflammation, some kind of protein things. So IL-1B, beta. So some people try to inhibit these things to minimize the response. As you see here, multiple this kind of cell types are working in this sort of ulceration, inflammation, other things, or the cytokine immune cells are working. And we are seeing reddish, this border and peripheral edema on clinical. So what cause of FUO? Well, in adult, about 20 to 40% are infection, bacterial or viral infection. But the other, about 25, 1/3 is related to cancer. So cancer, particularly lymphoma, caused fever. And then the other 10, 20% caused by autoimmune disease. IG4 disease is a new disease, IG4, granulomatous disease, and the polyarthritis, that kind of disease. In children, half is infection, and much less is either cancer or autoimmune diseases such as juvenile rheumatoid arthritis. So in infection, as I said earlier, TB is the most common bacterial agent worldwide. And then HIV, certain cholecystitis, cholangitis, osteomyelitis, urinary tract infection, gingivitis, sinusitis, fungus, and cytomegalovirus virus in immunosuppressive patients. And in cancer, there's a lymphoma, cause mostly fever, leukemia, Castleman's disease, and renal cell, atrial myxoma, and hepatomas. Those are the tumors were related to fever. When autoimmune disease, lupus, and the polyarthritis, polymyalgia, cryoglobulinemia, and Still's arthritis. Other things, thyroiditis, sarcoid, Whipple's disease, and pulmonary emboli, and hepatitis, and certain drug of fever. That's a cause. So to rule out every disease, we still don't know what's the cause in 10 to 15%. So here, FTG often shows unexpected infection. FTG accumulate in the macrophage, so it's more like a chronic infection. So as you see, it's old slide, but shows a very focal, intense area in the mediastinum. So that's there were a lot of studies for FUO, and then FDG certainly helpful in half or some. There's a various, numbers very low, very high. These relate to selection bias, selection. So, but if we see, very helpful. If we don't see, still don't know. Yeah. So in the lung, as you know, it has coronavirus, but bacteria, fungus all create pneumonia, and then eventually fibers. Early fibers has a very significant vascularity. Fibroblast is vascular, but later is sort of a scar tissue. Bronchitis or influenza, and some mycoplasma, and the other rare chlamydia, Bordetella, that kind of thing. So the pneumonia caused mostly by bacilli, pneumococcal pneumonia or streptococcal pneumonia, Haemophilus influenza, mycoplasma pneumonia, influenza, COVID-19, etc. So in chronic airway infection, quite often oral microbe, as I said, there are more than 500 microbes in the mouth. If you swallow, saliva goes, and then sometimes it goes. And then certain airway, this kind of Pseudomonas, Staphylococcus, and then some other things makes a pneumonia or lung abscess. So in 2020, just about a year ago, World Molecular Imaging Society surveyed any working for infectious diseases. Yes, was about almost 60%. And then are you working on this new research in infectious disease? Yes, COVID-19 was the 60%. Certain bacteria, other diseases. So COVID was certainly quite popular in research and treatment. So infection, for the infection imaging, you have to think about the pathogen-specific imaging, pathogen, to improve diagnosis. And then you have to imaging immune response so that you can understand the pathogenesis clearly. And then certainly imaging can have a serial imaging can have a pharmacodynamic, pharmacokinetic information about certain, antibiotics or any antimicrobial agents, so that we can optimize treatment by knowing certain pharmacodynamics, pharmacokinetics, or now recently pharmacogenetics. So the role of infectious imaging is number one, diagnosis and monitoring disease progression, underlying pathogenesis, and optimizing treatment, as I mentioned. So in nuclear medicine, clinic, we can detect inflammatory disease by utilizing FDG, PAS-CT. But FDG, as I mentioned, is attached to macrophage, so only maybe chronic inflammation can demonstrate. But you can also utilize the FDG PET for monitoring therapy. And also unusual inflammation in the myocardium, pericardium, certain muscles, and intestine or CNS. And the imaging research certainly can provide the therapeutic principles. Also, imaging can be a biomarker. If we image inflammasome, and then we can also titrate certain drugs, COX-2 inhibitor. COX-1 is more likely cardiovascular problem, but COX-2 inhibitor, like Cellular, as I mentioned, and also post-inflammatory fibrosis can be easily evaluated by new radiopharmaceutical using antibody against fibrosis, fibrosis antibody peptide. And then this certainly inhibition of cellular internalization of COVID virus can be studied by inhibition of angiotensin converting enzyme. So, particularly in coronavirus, we have to image virus itself. We have to also image inflammation and post-inflammatory fibrosis. We certainly have to generate pharmacodynamic, pharmacokinetic information and biodistribution of vaccine localization of, and immune cell activation is also important after vaccination. So here you see, okay, excuse me. MR show, particularly this post-contrast show ring shape, so lots of edema around, and certainly certain metastases could show like this, but the edema, all things, and clinical history can make this kind of a sort of brain abscess. So this is a very thick wall surrounding edema, central necrosis. That's this is probably DWI imaging. This is ADC imaging showing restriction of macromolecule in the abscess. Now, this, you can see sort of a perivascular contrast enhancement. Just the line, periventricular horizontal line after contrast injection. And then a sort of vague haziness increase signal intensity on DWI, diffusion imaging, show restriction. And ADC map is opposite sort of a low signal, and some here things, it's a restriction. That's again, it's a viral sort of a encephalopathy, and here another one is white matter, sort of a some perivascular hyperintensity diffusion on FLAIR image, and particularly this area. And then also thoracic spinal cord has some irregular or non-uniform signal, high signal intensity. And you can see better here. Now, there's kind of anything, a diffuse process is indicating either inflammation or infiltrative tumor like leukemia, lymphoma, kind of things. So in the clinical context, this is more like a diffuse inflammation and okay, this sort of alveolar density increase ill-defined, and this maybe interstitial density with air bronchogram. Various patterns, some nodular here, multiple lower lobe things. It's COVID pneumonia. And certainly not only infiltrate, some consolidation, some fluid together, this air bronchogram here. Yeah. There's an abscess, some air pocket here, and fluid, some here, air pocket, abscess. Again, in the liver, multiple and fairly large and large. This cystic was somewhat enhanced small, this abscesses by superbug. And as you see here, this is pancreas here. And you can see a small area of a low density, that's more likely small necrosis. This may be a little bit edematous. Here is more. And so this is a known acute pancreatitis with maybe small necrotic area or fluid collection. And again, this is enlarged uncinate process and dilated pancreatic duct is a mass here, but not, it's a sort of a irregular enlarged, but it's not well defined certain tumor-like nodule. This is just a chronic inflammation, so-called pseudotumor. It's enlargement of this. And this, you can see some kind of this contrast study, some delineation of bowel wall things is due to enhanced mucosa by cross-region differences, inflammation here. And certainly this kind of bowel infection caused some mesenteric fat stranded. Unlike fat density here, it's you can see some of the fluid things, haziness together, or that's an inflammatory response. And certainly diverticulitis is a common cause of certain mesenteric inflammation and some dirty fat in the mesentery. You can see some fat area, it's a haziness. And certain here, some inflammatory focus here in the momentum. Here is air, it's a rhyoiliopsoas muscle here. It's a edema and it's air, that's abscess here. And sigmoid colon and salmonella infected, the wall is thickened. One thing here. So the image infection, we like to have some radiopharmaceutical which is rapidly localized and retained at the site of infection. And also we have, that agent has to be cleared fast from non-infected tissue. So we can see the highest target to non-target ratios. The uptake radio tracer should be proportional to the degree of infection. So if we see less uptake, that's a lot more, sort of active infection. And therapeutic response can be easily monitored with that. And the labeling should be simple, easy. And particularly with the technetium 99M, that's cheaper. So it will make a cost effective and does not depending on host leukocyte function. Many such febrile patients do not have much leukocyte. So we cannot label leukocyte with a patient leukocyte. And certainly money issues big one. So what is the specific imaging? Label the leukocyte for acute infection. Acute infection usually show high increase in neutrophil. And then radio-labeled anti-granulocyte, monoclonal antibody has been used, and then we like to have certain chemotactic peptide with simple technetium type labels, and certainly cytokine, IL-6, 2A, that kind of thing. And then we like to target inflammatory mediator. So E-selectin antibody is a mediator. So anti-E-selectin antibody will be useful to see the response. And then target must have some kind of microorganism. So we can use a labeled antibody like a ciprofloxacin and some antimicrobial peptides. And then we like to target metabolic activity in the infection using FTG. So specific inflammatory infectious imaging agent are related to metabolism. As I said earlier, is a sugar substance or cellular wall part or a nucleoside analog or transferrin, so citrate. And certainly antimicrobial peptide, ubiquitin, antibiotic itself, and the glucoside has been labeled with the indium 111 oxin or technetium HMPO labeling. And eptamer or oligomers, Staphylococcus aureus, antibacterial, and the Bateriophages. And the vitamin, particularly vitamin B12, and others sort of prothrombin and lipid in the bacterial metabolic process. And the labeling leukocyte has been done with the technetium, indium, FTG, or that kind of thing. And as you know, FTG is more likely glucose metabolism. And the anti-granulocyte antibody, and then immunoglobulin has been labeled. And then cytokine, anti-TNF, and IL-2, IL-A, and then inflammatory markers like E-selectin has been labeled with technetium. And then for lung infection again, metabolism, cathepsin for proliferation, immune cells, hypoxic cells, apoptosis, and annexin has been labeled with technetium. And that's but this one is similar to that. And then certain MRI also can be used. So I'm sure you have all experience with the gallium-67 citrate, indium-111 leukocyte, technetium labeled 99M labeled the leukocyte. And their physical properties are slightly different. And gallium is a half-life 78. And then 4 multiple peaks gamma. And then indium is 67-hour physical half-life. The optimal is gamma energy 170 to 140 kb for good pictures. Here you have to combine all 4 energy level for gallium-67. And technetium, obviously, 6 hour, 140 kb optimal energy. And the infection, the imaging time is different. This diagnostic imaging should be done at 48 hours imaging of gallium-67 citrate. Indium leukocyte imaging, 24 hours. 4 hour, 6 hour imaging show lots of long activity leukocyte, but 24 is clear. And anti-granulocyte antibody, usually 1 hour, 2 hours. Technetium 99 HMP or leukocyte, usually 1 to 4 hours. Multiple time point imaging important. So 1 hour, usually 3 hours or 4 hours. That's it. Chemotactic peptide has been labeled FDG. FDG, optimal time is 6-8 hours for tumor infection. But if you wait that long, you're not going to see anything because 2 hour physical half-life of F18. So mechanism, okay, gallium-67 citrate is bind to the transferrin, So maybe any capillary permeability may be the reason, but we don't know yet. Or IgG is non-specific IgG immunoglobulin. And certainly, anti-NCA 90 FAB prime, that's called leucoscan. And so that has been used. And certainly, albumin nano colloidal particle has been, but these are non-specific. And that's related to vasodilatation, hyperemia. And then target cellular mic. So leukocyte goes to the certain infectious or inflammatory area by certain cellular migration. And the FDG is metabolic trapping attached to the macrophage. A receptor bind interleukin 2 or A or receptor. Specific micro, they labeled drugs, ciprofloxacin, labeled with technetium. So that's directly bind to the DNA enzyme. So gallium-67, usually the marrow go large into bowel. Bowel activity is a critical organ. Bowel activity. Indium 111 auxin leukocyte. Spleen is sort of a critical organ, spleen receiver. Technetium labeled HMPO, W leukocyte. The bowel is a critical organ, bowel. So gallium-67 citrate bind to the transferrin and then cross and the cellular membrane, it goes to the intracellular, and then stay there. Glucose and then phosphorylated, and then finally TCA cycles, and then finally make a carbon dioxide and water. But FDG is phosphorylated and stopped there. So we are looking at this. Yeah. So gallium-67 is good for chronic infection. Indium 11 leukocyte is good for acute infection. So gallium-67 citrate has been useful for evaluating sarcoidosis and pulmonary fibrosis. So how come idiopathic pulmonary fibrosis takes up this kind of agent? Nobody knows. But in early stage of pulmonary fibrosis, fibroblasts are quite a vascular, so transferrin goes there. And then certain toxicity somehow, the particular pneumocystis carinii nowadays is zero valency. This takes up gallium-67 citrate diffusely very well. So low-grade chronic infection is good with this agent. Immunosuppressive patient, good. And so, and also it's good for hepatoma. Now here, there's a normal, the breast, usually it's the liver and mild activity in the marrow, but notice lacrimal gland normally, so lacrimal, normal. So sarcoid uveitis will show similar, but much more intensity, sarcoid uveitis. So this one is old fracture, it still show old fracture. So bone scan the phosphate compound or gallium-67 citrate show old fracture for long time. I've seen that for 20 years. As long as there's a continuous healing process, it will show. So the skull base, a certain lesions, this clivus here is the most commonly here, certain the meningioma, clivus and petrous bones here, slow growing to me show FDG, this brain, FDG also shows some uptake, but this is not the meningioma. This is the right side sort of otitis. This is hard to believe. This otitis. The ear should be. This could be inner ear, but this is almost like a cerebral pontine angle on axial, and this is not a good picture to show right side or side. This is from the literature. And as you see here, this sarcoid uveitis, and a lot of cerebral gland takes up, and classical sarcoidosis show almost symmetrical bilateral hyla. This is called lambda sign. This is called panda sign. The Chinese dog, panda, look like. And then sarcoid bilateral. And when you look at this is either sarcoid or leukemia, lymphoma. Those all show symmetrical bilateral hyla, perihyla lymphadenopathy. And this bleomycin toxicity and certain this pneumocystis carinii pneumonia show like a diffuse thing. So diffuse things in cancer patient who receive certain chemotherapy show like this, but otherwise, you have to think other things, diffuse pneumonia or some other, like a fibrosis, other things, of course. So it's a similar bleomycin is busulfan is common, nitrofurantoin, cyclophosphamide chemo, methotrexate chemo, and the nitrourea. Why show diffuse? We don't know. So they are this show all this agents show 80, all depend on how they select the patients. It's around 80%. That's why it's useful. But we have we need a better agent for more higher sensitivity or more specificity. And then this for leukocyte, Indian leukocyte is better than technetium because we have a multiple time point imaging and stable, labeling is stable. Technetium is not stable. So we can have also delayed imaging in this case. So there's nothing in the bowel or kidney, but technetium shows, so that's why. So for acute means less than 10 days or 2 weeks, febrile, looking for source of infection. The Indian oxin leukocyte is a choice. And the chronic is gallium-67 citrate or F18FDG. So this is nothing here. When you see intensity increase spleen, you have only 4 choices. Number 1 is a octreotide somatostatin receptor imaging, show intense, but that study should show kidneys intensely, kidneys. Next is a cell labeling, red cell, platelet, white cell. Red cell platelet show activities retaining in the cardiac pole or major vessel, aorta, inferior vena cava. Platelet is much smaller number, so leukocyte, red cells show a lot more activity, and platelets show a little bitty. But in this kind of leukocyte image, nothing, kidney, nothing. So if you see bladder, that's a cystitis. And in 4 hour, little bitty lung macrophage, but 24 hour clear, everything clear. Some bone marrow, little bitty bone marrow here. That's a normal. And so if you have this ulcerative colitis. Ulcerative. So after they treat steroids, and we can monitor. So ulcerative colitis. Certainly in small bowel, regional enteritis should be suspected. And it's again, sensitivity 89. And it's certainly Crohn's disease in small bowel. And nowadays, our specs, the old days expected still show better certain inflammatory agent, but 3-dimensional SPECT-CT is the best. Certain diverticulitis, other things. And certain post-operative wound things easily detected with the leukocyte, granulocyte, hepatic abscess show here. These are all proven case. And certainly diffuse activity ill-defined peritonitis or peritoneal. Certain cancer also takes up leukocytes. So peritoneal carcinomatosis will look like. Abscess certainly splenomegaly, intense activity. As I said, you have a bladder here because of technetium label. Technetium, certainly free technetium show this and some thyroid things. And then here, little spot, small spot that has been found and correlating with the air, this abscess, technetium. And then certainly this osteomyelitis, usually metaphysis, close to the epiphysis, is not easy to detect. So you need the SPECT-CT to show any asymmetry things. And false positive, negative, all this has been well known. Certain false positive bleeding, leakage of labeled one, and then certain fracture, wound, hematoma, cancer, etc. And then negative one, certain unusual vertebral osteomyelitis in children, things do not show white uptake somehow. They don't have much neutrophils. And then certain chronic infection may not show. So most chronic use a lymphocyte monocyte and certain therapy effect also. So here, okay, and some we have no spring here, but we have something in the left upper quadrant. And then here on spec show here, this is called splenule. After, during the surgery, splenectomy, they can spill the spleen cells and regrouped and growing. So choice is indium 11 leukocyte if you have indium, but otherwise technetium labeled red blood cell. All cell labeled radionuclide will go to spleen tissue. Spleen is sort of end organ type thing. So white cell, platelet, or red cell will all show similar finding. And then certainly transplant kidney rejection also show leukocyte uptake. Rejection is more likely immunological phenomena, but there may be some kind of inflammatory reaction. So there is a HMPAO show CD 24 hours show last lung activity cleared. And then later it's a bowel activity. It's hard to interpret whether this is a free technetium excreting here thing, technetium. So now bacteria infection, I have to move fast, sorry. It's PET imaging certainly has a higher sort of spatial resolution. So smaller lesion will show better, but it's more expensive. Cyclotron producing isotope is a lot more expensive. So it's a PET, using PET, FT PET is a very high resolution, as I mentioned, but the cost expensive. But more important to me is non-specific, no specific. FTG is not specific for tumor or infection. It goes every, any area will increase the flow. Tumor, infection. So it shows chronic osteomyelitis, diabetic foot, and FUAs infection. So in this case, tuberculosis show, and in mediastinal, all this opacity shows more mediastinal abscess. And then it's here, lung apex show tuberculosis, active, inflammatory. So we can evaluate pharmacokinetic information we can generate of the antibiotics, how they go, where they go, how fast, where they, how much they excreted, etc. And this bacterial, all this, anatomy. So this fampicin attack this polymerase in RNA. It's inhibiting protein synthesis. So this is a chemical structure, and using the C11 labeled rifampin. It shows, so it's, here MR shows diffuse edema, all the thing. Here show infectious portion, and the periphery. It's a sort of a meningitis type. It's a meningitis, and this is a long as a TB show here. And this radio-labeled drug like zanamivir, or vir is like a viral drug. So encyclovir, all the things. And this show some, the one is human, the other is primate. And this drug or this has been labeled with a positron producing emitters. And the drug like ciprofloxacin has been labeled with the technetium-99 and also F18. The 4-6 hour shows significant increased activity around the right hip prosthesis. So whenever we have a prosthesis, we have to worry about loosening or infection. Loosening usually should increase uptake in the proximal or distal portion of prosthesis because of continuous irritation. But infection along the side or diffuse. And this sorbitol I mentioned is fermented by bacteria. So we're using this F8 and FD S fluorodeoxy sorbitol show significant uptake. Inflammatory lesions show up because bacteria utilizing this sugar. So it's a response of therapeutic is here and much improved, much less means improved. And the myositis, certainly here you can see on sagittal, coronal, and transverse. And FTG doesn't show much. So either very acute or not much. So it's sometimes this kind of image helpful. And certainly this utilizing sort of para-aminobenzoic acid labeled with the C11 shows a certainly gram-negative lesion. This bacteria synthesize folic acid from this PABA. So clinical gram-negative bacteria usually cause a lot more problem. Drug resistance also a lot more common in gram-negative. So we monitor antibody response, and so it's a before after treatment, and then see how much changing is improving. Less activity means less antibiotic goes there working, so it's improving. And for viral diseases with the FTG, well, as long as there's a significant glycolysis, it will take up. So influenza virus, dengue virus, Mersco all show. Again, COVID-19 pneumonia also takes up here, but nothing, added to CT findings. And it's all just classical infiltrative consolidation here, and then the text show before treatment and after treatment cleared. And certainly vasculitis, curvilinear mostly, that kind of, so large vessel, medium and small vessel show atherosclerotic changes, but Takayasu arthritis, giant cell arthritis, polyarterinosus, Kawasaki disease, all this granulomatosis or polyangiitis, those things show uptake, macrophages, some inflammatory reaction is associated with that. So in atherosclerotic, the vascular system, all these immune cells are working, and so, but some cells taking this dotatate neuroendocrine cells here, some, yeah. And so scleroderma, lupus with FTGs show some uptakes in the posterior chest uptake here. Certain hepatic abscess also chronic. Infected, certain here. And here. And this is important that in the certain cystic lesion, which become infected, then CT-MR is not easy to show infected cyst. And so with the FTG showing infected cyst, they can drain this pus or things and put the alcohol things. So this is important to find the infected cyst. So this is another, a lot of cysts. Which one is infected? You can't tell. But the FTG shows certain infected cysts. So there's a granuloma, or this is almost like a lymphoma. This is here, but this is a fungal granuloma. And certainly cardiac sarcoidosis also is showing some, in Western, there's a lot of granulomatous, multi-system, but this cardiac environment is important because of possible heart failure. And it shows, tetraphylline shows decreased blood flow, but FTG show uptake in the area of sarcoidosis. It's a classical lambda, or there's a sign, as I mentioned, all this cardiac sarcoid all show. Sarcoid has also some neuroendocrine components, so DOTA NAC takes up. Yeah, this is almost fibrotic. Yeah, ulcerative colitis. You can see here with FTG, that's a metformin sort of influence, but ulcerative colitis can show just like this. So IG4 auto pancreatitis, usually multi-organ system things. So all this lymph node inflammatory, chronic inflammation. Graft inflammation also show very well using FTG, so you can see all three dimensions. So that's important. And certainly spinal sort of osteomyelitis. As I said earlier, indium leukocyte may not show anything, in particular pediatric case, but FTG show. So it's a three-phase bone scan, still used as the gallium, all thing 80, 90%, but those are not specific, these are still not 100%, it's all 80%. So stenotomy after Yeah, surgery is a sort of a, right after surgery, you also increase activity because of blood flow and healing process. But after a certain period, like 6 months later, things, there's a more likely infected surgical wound, things, infected spinal fixation or Harrington's rod and pain is infected, FTG can easily show. And all the disc, discitis, vertebritis, all this arthritis, infected arthritis. You can see little swollen here, but it shows clearly all this FTG uptake. And the certain cellulitis, septic arthritis all show very well. Using this nucleotide agent, you can see also very septic arthritis, cellulitis. I show earlier FTG leukocyte uptake in the area of infection. So chronic infection show a lot more FTG. Acute infection is leukocyte. So to separate a sort of a normal regenerating leukocyte means we need the marrow scan often together. And so if marrow scan increase, then slight increased activity is just the normal regeneration of leukocyte. And the prosthesis hip is a common and infected show increase, I showed earlier. And so this all together, Indian leukocyte or technetium, sulfur-colloid marrow scan together is helpful to separating infection from regenerating bone marrow cells. And it's a thallus infection, osteomyelitis. It's a dynamic flow study show increase, and the blood flow image show increased vascularity. Delayed show more like a donut-shaped lesion, but central necrosis surrounded by active inflammatory cells. And again, great toe, increase the flow, increase vascularity, and increase the activity in the bone, the proximal phalanx. These are osteomyelitis of great toe. And certainly proximal phalanx, MR show gadolinium enhancement, the plantar, this inflammatory lesion, thallus osteomyelitis, FTG, PET MRI together is the best, soft tissue, marrow, and the scaphoid, the bone, septic arthritis here. So it's without SPECT-CT, it's difficult to call this kind of things. Rheumatoid arthritic environment first and second metacarpal, and this increase sort of activity and PET MRI show. So finally, all this, again, this technician labeled antibiotics should be very useful and cost effective. So it's been all reported, but we don't use that much nowadays. Just the MR or the clinical judgment use. So we have to educate more to our clinicians that we have more specific imaging for infection. So as I mentioned, we have a lot of new agents utilizing peptide, certain even bacteriophages. And so it's a more specific imaging agent. So antibiotics, infection. Okay, I have to move fast. So this fluorescent imaging versus bioluminescence imaging. All the research papers show all this kind of fluorescent or bioluminescent. And the fluorescent, we have to excite certain element like a fluorophore to see the light. But in bioluminescent, we use luciferin that will be metabolized by luciferase enzyme convert. So it makes all this ATP, all the things. So during this process, there is a visible light comes. So it's a similar, but it's different source of light. So all this, okay. Finally, by using certain metabolite, optoacoustic imaging has been tremendously improved nowadays. In animal study, they detect even less than 1 micron type resolution. Very, very fascinating. There's maltose. This is a sort of maltodextrin, maltose bacteria utilized, and apparently this derivatives can separate the infection versus inflammation or inflammatory reaction. And so F18 has been labeled and then tried to show some, and then the paper shows some separation, infection versus inflammation. FTG doesn't show any significant difference, but this one shows. So that's this is a major clinical problem in separating infection, inflammation, cancers. So utilizing this kind of maltose derivative seems important. Our the radiochemists should continuously work on these things so that we can utilize this one to separate these things. And the, so as I said earlier, we have also utilizing this imaging to understand the resistance of certain drugs. So I don't have enough time to talk to you about those things, but I hope you catch certain key messages of utilizing various agents to improve diagnosis and the response of therapy, and also titration of certain toxic drugs like antibiotics. So, you know, this, I have too many slides, but recently all the neuro, you know, translocator sort of this kind of inflammatory agent has been shown in evaluating neuroinflammation. But this finally is fibrin. It's a post-inflammatory process will make a fibrin. Early fibrosis versus later is the all fibrotic changes, all things. The lung fibrosis, that's a major. Now is fibrin acting peptide has been all here, and some people labeled in all this radioisotope. So we should utilize such a fibrin imaging for not only infection but also cancer. As I mentioned earlier, optoacoustic tomography is very, very advanced now. So all kind of a new report, all that sense. So I have to stop here. These all things has to be transferred to the clinic for our use. So we all have to work together. And particularly we have to learn more and more this microbiome. There's all so many billion bacterial cells here control all our body system. We are living in a microbe world. Okay, so keep in mind to learn all this probiotics, other things to make our body healthy. Thank you very much again. If you have any questions or things, you can email me or whatever, contact me, then I'll be happy to answer. I hope you keep safe, healthy, and at least for next 6 months, so that I can probably see you on the online. Thank you very much. Bye-bye.
Bye-bye. Thank you so much.